Okay, everybody, I wanted to take some time to go over some medications in more detail for you. Okay, so I will start with oxygen, and you can consider this just kind of a, you know, intro to airway management. Okay, so what we're looking for with oxygen, all right? So anytime a person is experiencing something that we would consider respiratory distress, hypoxia, shock, things like that, we want to give them some oxygen. Whenever you're having difficulty breathing, some of you may automatically default to this being some sort of mechanical problem in your brain to where it's like for some reason the lungs are not appropriately expanding. Now, that being said, that can have something to do with it, albeit rare. What it actually is that this is your body's presentation to being hypoxic or not enough oxygen in your blood. So whenever you see someone who's struggling to breathe, you need to look at it as if they do not have enough oxygen and their brain is telling their body to starve and like really try to get that oxygen by overworking itself. That's kind of what you're seeing. Now, sometimes there are other things like congestive heart failure. You can have a bunch of fluid in your lungs, things like that, where there is some sort of complication there. But at the end of the day, it's all coming back to hypoxia. Now, there are three main delivery devices that we're going to use for oxygen therapy, okay, where we are just delivering oxygen. I'm going to show you what those are. So the first delivery device that we have is going to be our lowest concentration that we can use, anywhere between 1 and 6 liters per minute, and that's going to be the nasal cannula. Now, if you think back to the primary assessment lecture that I gave, the nasal cannula is not involved in there. And that's because we're using this as some sort of maintenance, maybe just a person is having just a minor amount of difficulty breathing. Maybe they're on home oxygen and they're on a nasal cannula. We want to continue that as we transport them. Maybe they're on a home oxygen at 2 liters per minute, but we want to give them just a little bit more. So we throw them on our nasal cannula at 6 liters per minute. This is not something that we are using to treat any type of life threat ever, okay, which is why the nasal cannula is not included inside of the primary assessment phase. The next one that we have is going to be the non-rebreather. So this is for that distressed patient, and this is where we have that primary assessment treatment where it comes up. It could be used elsewhere too, so treating for shock, things like that. And so what you have here is a mask with a reservoir bag attached to it. Now, there is a range that you can use this particular delivery device with, and that's going to be 10 to 15 liters per minute. I'm going to keep it real simple for you. I told you that I'm not a huge fan of us having ranges, right? So, that being said, anytime you use a non-rebreather, put it on 15 liters a minute. Okay. And then the last one that we're going to look at for oxygen therapy are going to be our bag valve masks. So there's 3 sizes of bag valve mask here. We've got adult, pediatric, and infant. There can be various kind of sizes sort of in between here. But overall, this is what you're going to see. And then this one's just always set this 15 liters a minute. And you're going to be perfectly fine. Okay. All right, so back over to here, I just want everyone to just kind of take note that there are no contraindications for oxygen, all right? There's never a reason to just withhold oxygen from someone, all right? At the same time, do we want to go throwing a non-rebreather on everybody? Also no, okay? So have some sort of indication that you're going to be using for, and that's where it comes back to this hypoxia, shock, or respiratory distress. Okay, so one thing that is going to be a skill that y'all are going to need to work on and understand how it works is putting one of these regulators here onto our oxygen tank. Okay, so there's going to be a little bit of a process for that. These oxygen tanks, they come with a little plastic seal around this part here. So you're going to pop that off, and a lot of times you're going to have this little washer, and it's really an O-ring that's going to be sitting there. So you want to make sure you kind of grab hold of those. Whenever you go into the room 215 in the skills lab, you'll notice on the windowsill that there are an absolute ton of those things sitting over there. All right, you're going to need a wrench as well as your regulator, okay? So you see you've got these two pins here, and then this piece here on the regulator yoke. So there's only one way that this goes in, really. You kind of can't screw that up. All right, so you're going to place the regulator on top of the tank. But before you do that, one of the things that you want to do with these is take this O2 wrench and just give it a gentle crack just to make sure that you're blowing out any debris that may be inside of this port. So next up, you're going to take the regulator, set it on top. You're going to use this T-handle here to go ahead and tighten it down. Now, you don't want to tighten this down like using the wrench to like crank down on this. Hand tight and snug is fine. Main thing is you want to make sure this washer is set appropriately. And some of y'all make the mistake of it just being just kind of slightly not really seated right. One of the things that you're going to hear me say a lot whenever it comes to this skill stuff is work the problem. All right, so if you notice that there's like a lot of leaking that you hear because your regulator is set to 0, it shouldn't be flowing anything, I'm going to tell you to work the problem. Well, your best option here is that your regulator is probably just not set right, okay? Or maybe the O-ring isn't in there, something like that. So turn the tank off with the wrench, undo the regulator, take a quick look at it, and then try to reseat it and see if it works better from there. 9 times out of 10, once you do that, it'll be perfectly fine. All right, so again, just to sort of recap this process, you're going to take off the little plastic cover here. You're going to make sure you got a washer if there's not one already on your regulator. You're going to take this O2 wrench, you're going to crack it real quick to make sure you blow out any debris here. You're going to take this regulator, 2 pins into these 2 holes, sit that in, trying to keep it as straight as you can. Go ahead, turn that T-handle until it's nice and snug, and then you're going to turn the oxygen tank all the way on. Make sure that there's no leaks, and then from there you can set your regulator to whatever device it is that you're using to deliver that oxygen. So I mentioned that we're using oxygen for oxygen therapy. Now we're going to kind of flash forward to something that we're using oxygen more as a delivery device with a secondary factor of it being oxygen therapy. But I want you to recognize this as being an oxygen delivered medication through a nebulizer for it to be inhaled. So that medication is going to be albuterol. So this is going to be a bronchodilator. All right, and what this is going to do is you've got these beta-2 receptors, okay? So that's just these particular types of receptors. You've got a lot of them in your lungs and a few of them in your heart, all right? And once this albuterol gets in there, it's going to bind to these receptors and it's going to kind of agitate them a little bit, and that's going to actually make the bronchus start to expand, right? So with asthma, you are getting a lot of constriction. Here, let me show you. Okay, so here's a set of lungs here, and these are going to be just some regular lungs, and then we have our main stem, our trachea that's going to move into distributing that air throughout our 5 different lobes. So if you notice here, everything's nice and open. Plenty of highway for that air to move on. But during asthma attack, you have a lot of inflammation followed by mucus. Some mucus development starts to happen in here, all right? So inflammation followed by that mucus development, all right? And then so what's happening is instead of having these nice deep breaths that you're seeing here, now we're getting just these really short, rapid, painful breaths, all right? One of the sounds that you're going to hear with this is going to be something called wheezing, and this is what that sounds like. So that's what that wheezing can sound like. So what we're going to do to treat that is we're going to give asthma. Okay, now there's also times that you can hear wheezing, and it could be with COPD, other things like bronchitis, emphysema, stuff like that, which is why whenever I'm talking to you about the indications, I want to keep everything nice and simple, and that's going to be wheezing or stridor. We're going to get to stridor a little bit later. Main thing I want you to care about right now is wheezing. I'm going to show you where this comes from. So this is the adult COPD slash asthma respiratory distress, kind of a catch-all protocol, if you will. But you'll notice right here, this is where our very simple to remember indications are going to come from. Zoom in just a little bit. You're going to do your usual primary assessment stuff, and then once we get through with that, then we're going to do lung sounds. Are they wheezing? If yes, albuterol is indicated. If they have stridor, also albuterol is indicated. Okay, you can see here that we can repeat as needed 3 times. All right, repeat as needed 3 times. So again, you see that there's dosage ranges here, 2.5 to 5, and like I said in our first lecture, I don't like ranges, especially for initial students. Adults get 5 milligrams, pediatrics get 2.5 milligrams. Now, one of the big contraindications for albuterol is going to be EMT administration of beta agonists, which is what a albuterol type drug is limited to only patients currently prescribed the medication. Okay, so your indications are going to be wheezing or stridor, but a contraindication is going to be having to have a prescription, right? So if they do not have a prescription, then that means that is a contraindication. You cannot give them that medicine, all right? Indication is wheezing or stridor. Contraindication is not having a prescription. Now, another contraindication would be an allergy, okay? That's pretty common contraindication for most stuff. All right, so back over here, just to kind of wrap up this albuterol, is that again, we're going to be looking at our adult dosage as 5 milligrams, okay, and then a pediatric dosage as 2.5 milligrams. All right, so again, we're going to have a contraindication of hypersensitivity slash allergy, as well as they must have a prescription. Okay. Then we're going to be looking at how are we going to deliver this medication. All right, so let's take a look at that. So what I'm showing you here is something called a nebulizer, all right, a nebulizer. And what this is going to have is a nebulizer reservoir here, and this is where the medication is actually going to go. You just take these little tubes of the albuterol and you just squirt that medicine right into here. It sits right here. Then this is called what we affectionately refer to as a peace pipe, but this is a main delivery device that is the preferred route where the patient would put their mouth here. This allows for the medication to kind of stay concentrated here in this general area, and then they just, the instruction is generally just, take in as deep of a breath as you can, hold it for as long as you can, and then slowly release it. And you just keep breathing, all right? And then all of that is going to be powered here by your oxygen tank. So remember, this is a oxygen type of powered delivery device. And your setting for that is going to be 4 to 6 liters per minute, all right? 4 to 6 liters per minute to get this nebulizer running. Another thing that you can use if you have a patient who is in just extreme distress, they don't have the energy to really hold this thing, and they just need a little bit more help, is there is a separate mask here that they can put on, and really we just take off this piece right here. We just take that off, and then we're just going to take this nebulizer piece, and then we're just going to pop that in right here, and we're good to go. All right, same oxygen flow, whether you're using the peace pipe or this mask right here. All right, so to kind of take a kind of step away from some of the respiratory stuff, we're going to talk a little bit about activated charcoal. Now, remember I told y'all this is one I didn't want you to, just completely beat your head into your book trying to learn, but I need you to know, a good bit of it. All right, so we need to make sure that we're proficient with this. Okay, but I can go ahead and tell you that I want you to make sure that you have all these other medications down before you try to get into something that's a little bit more complex like this one. So this one, we're going to consider this a adsorbent, and really what this is going to do is it has real charcoal in it. All right, and that's going to, real charcoal having all of these different pores and different things like that, it's really good at absorbing stuff and having it bind to them. So these toxins are going to want to bind into it, and then your body is actually just going to pass it through the digestive system. Okay, so there are select poisonings that we're going to use, okay? And I'm going to show you the protocol here in just a second whenever we get into indications and then contraindications for it. So, your dose, all right? Your dose is always going to be 1 gram per kilogram, okay? So you've done your med math, all right? You got to get this patient's weight into kilograms, and then it's going to be 1 gram per kilogram. So once you get it into kilograms, it's not that hard of math, okay? All right, so this is going to be the overdose and toxic ingestion protocol, which is going to be TB8, all right, or sorry, TE7. And there's several different things that we can use activated charcoal for. So you can come through here and you can start looking, and our first one over here, we're going to be looking at Tylenol overdoses as well as aspirin overdoses, as well as beta blocker or calcium channel blocker overdoses. All right, and then finally a tricyclic antidepressant overdose. Okay, so you'll see here that we have some main things that we have to worry about here. So those medications, Tylenol, aspirin, beta blocker, calcium channel blocker, and tricyclic antidepressant. Those are going to be our indications, all right? Now, our contraindication is going to be if that ingestion occurred greater than 1 hour prior to your arrival, all right? Greater than 1 hour prior to your arrival. The other main contraindication for this is going to be unable to follow your commands or protect their airway. When it comes to dosages, again, I said it was 1 gram per kilogram, and that's going to be PO, so they're going to have to swallow it, all right? And there is a maximum of 50 grams, all right? 50 gram maximum. All right, so now we're just going to jump over here to oral glucose. This one is pretty simple, straightforward, all right? And this is just going to be, for lack of a better term, it's really just sugar gel, all right? This is glucose, so it's not as simple as like a dextrose, but it's still a pretty simple sugar that the body can break down pretty quickly. And so this is just going to be something that we want to be able to get into the bloodstream as soon as possible. So our indication here is going to just be hypoglycemia, right? So we're looking at 70 on the CBG or lower, all right? So whenever you take that blood sugar, we're looking at less than 70, and they can get this oral glucose, so long as there's no contraindications present. Right, so your indication is going to be less than 70 on the CBG, but your contraindication is going to be unable to follow your commands or protect their airway. Adults are going to get 1 tube of this, all right? That's going to be about 15 grams. Pediatrics, you start with about a half, all right? Okay, so next up I'm going to go over 2 different medications, aspirin and the nitroglycerin, then we're going to take a look at the protocol. So first things first is going to be aspirin, all right? Aspirin is a NSAID, so a non-steroidal anti-inflammatory drug, all right? But it is also a antiplatelet, all right? It is not a blood thinner or an anticoagulant. This is a antiplatelet. Let me explain a little bit more. So first, I'm just going to really try to show you what a blood clot actually is. Right? Whenever we look at a blood clot, we're dealing with red blood cells. All right, we're dealing with some white blood cells in there as well, and then they are all held together by this sticky sort of fibrous structure known as fibrin. All right, so now let's look at this clot trying to form whenever we give it an antiplatelet drug or aspirin. So our clot is going to begin to form here. All right, that's where all those cells are starting to stick together. However, our aspirin comes in, and the platelets that are in there are a key component of this because they're really what makes the thing sticky, especially in the early part of the clot development. So once we knock those platelets out and prevent them from being able to have this chemical reaction by using that aspirin, then that is going to allow this clot to break up and start flowing away. All right, so back over here at the aspirin. All right, so our indication is going to be pretty simple: suspected cardiac chest pain. Once we get to cardiology and some of that chapter, we're going to really learn a lot more about what we are going to do to suspect cardiac chest pain. All right, right now, the main aspirin that you're going to see is going to be these 81 milligram tablets here, all right, 81 milligram. Now, you're going to give 4 of those, okay? So 324, sometimes in adult aspirins like 323, 325, stuff like that, all right? But you just stick with 4, 81 milligrams, that's the most common. And then your patient is going to chew those up, okay? So they're going to chew it up, and then once they get them chewed up, they're going to swallow it. Now, our indication, again, is going to be suspected cardiac chest pain. But what about a contraindication? Okay, well, aspirin allergies are very real. All right, so we need to make sure that they're not allergic to any to any aspirins. Okay, then you don't need to have basically any recent GI bleeds. Okay, so that's going to be any bleeds in their stomach or intestines, things like that. All right, and then if they have any type of crazy bleeding disorder or anything, then the aspirin will be contraindicated. Okay, so the next one to look at is going to be nitroglycerin. All right, let's talk a little bit about how nitroglycerin works. Okay, so nitroglycerin is a vasodilator, all right? So you have vasoconstrictors that make a vessel smaller, and then you have vasodilators that make them larger, all right? So there's 2 different main indications for nitroglycerin. The first is going to be suspected cardiac chest pain. The second being symptomatic congestive heart failure. We're going to talk about the suspected cardiac chest pain first. Okay, so what nitroglycerin does is it's a sublingual medication, and your indication's met. Now you need to make sure that there is no contraindication, all right? We're going to talk more about those in detail, all right? But you're going to give them 1 tablet. We can repeat this up to 3 times. And how this is going to work is that it's going to dilate specifically the arteries and the arterioles around the heart. So the idea is that there is some sort of clot that's causing this cardiac chest pain, and that is going to hopefully be freed up and not be as obstructive by the allowing more blood to flow around it because we have opened that vessel up some more. Now, on the second part of the indication, that would be the symptomatic congestive heart failure. Generally, this is going to be given whenever you have a patient who's experiencing pulmonary edema or fluid backup in the lungs, okay? Because that fluid's backing up because the heart is not effectively pumping. So what we will be doing is we will give them a nitroglycerin under their tongue, to, again, dilate the vessels. Especially now we're looking more at the vessels that are running in between the lungs and the heart, which is going to allow a greater space for the fluid that's in the lungs to be pushed down back into those vessels. All right, so that's your two indications and kind of how it works there, but let's take a look at the contraindications. All right, so your contraindications obviously are going to be allergies, but here's the main thing is that they must have a prescription. All right, they must have a prescription for nitroglycerin. So if they're prescribed the nitroglycerin and it's their prescription, then probably not going to have a hypersensitivity or an allergy to it because they've already been through the screening at their physician's office. They've been prescribed this medication for them to use it. All right. Now, a couple other main contraindications that you must be aware of. The first being the presence of hypotension. Right. So what that means is that if the patient's blood pressure is less than 100 systolic, then that is a contraindication for nitroglycerin. Your other contraindications are going to be a recent use of Cialis, so that will be within 36 hours. Or they have used Levitra or Viagra within 24 hours. Those are going to be your contraindications there. All right? So now let's just take a little look here at the chest pain protocol. So to begin, we'll talk more about what the 12-lead ECG procedure is once we get to that in medical in several weeks. All right, but talking about pharmacology, first thing we're going to do is aspirin, 84 milligrams times 4 chewed. All right, or a single 325 milligram aspirin that would be chewed. All right, notice how this is in red. All right, well, let's remember that items in red text are the key performance indicators for the EMS Acute Cardiac STEMI Care Toolkit. Okay, so that means that it's really important. Right, aspirin is scientifically proven to be way more outcome positive than things like oxygen, nitroglycerin, all that stuff, right? These 4 little baby aspirin are a huge deal for these patients. So that's why we want to make sure that they're getting a aspirin first, right? And then if they are prescribed to the patient and BP is above 100, there's no Viagra, Levitra, Cialis type stuff going on, then a nitroglycerin would be given sublingual every 5 minutes up to 3 times. Okay, and that pretty much sort of sums up the EMT scope within the chest pain protocol. All right, so moving on from the cardiology drugs, we're going to talk about Narcan or naloxone. Right, this is going to be a opioid antagonist. So this is going to get into the brain and those opioid receptor cells. It's going to block those off. Right, and this is going to just really start knocking these different opioid cells back out into just the brain for them to be processed and wasted out. So that way, the nasty parts of these overdoses, specifically with the respiratory depression, is going to hopefully stem itself off. So your main indication here is where you're going to have a unresponsive with ineffective breathing patient with a suspected opioid overdose. Looking more into dosages, things like that, we're not using this to restore consciousness, all right? We're using this to give more respiratory drive, all right? So you're having patients who are barely breathing, and we're going to give it to them to increase their respiratory drive. All right, so there is a range. Adults, 0.4 milligrams to 2 milligrams. Pediatrics are going to be 0.1 milligrams per kilograms. So you want to remember that there is going to be a 4 milligram total max amongst all the dosages here. And then again, I don't like ranges for initial EMT students. So for adults, you're going to give 0.5 milligrams per nostril as a single dose. All right, so 0.5 up one nostril, 0.5 milligrams up the other nostril for a 1 milligram dose. Okay, that is going to be a really good starting point. And then after 5 minutes, if there's no improvement, then you can do that again, 0.5 milligrams up one nostril, 0.5 milligrams up another nostril for another 1 milligram dose. All right, pediatrics, you're going to come up with 0.1 milligrams per kilogram. Do the math with that. This is really easy. Once you get the kilograms figured out, all you need to do is take that decimal that's at the end of the number and then move it right over to the one space to the left, and you're set. All right, that gives you your 0.1 milligram per kilogram dose. All right, we'll talk more about the nuances of that in class. Now, when it comes to contraindications, there are none. All right, don't have to worry about those at all. Okay, Benadryl. Benadryl is a complicated drug, especially once you get to really digging into the protocols about it. All right, so I'm actually going to be, um, potentially making a assignment that is going to kind of make you sort of go figure this stuff out. It really depends on how y'all do in class once we start messing around with this. All right, but Benadryl, we've all taken it before. All right, Tylenol PM, straight Benadryl, whatever it is. It's an antihistamine. It's going to block H1 histamine receptors. You don't really need to get into all that stuff, okay? So for its indications, it is technically allowed inside of mild and moderate allergic reactions, but not a severe allergic reaction. So I'm going to show you the protocol so you can kind of understand this. So we've got three types of allergic reactions here. We've got mild, which is going to be skin only. So that could be somebody with a rash or hives, okay? This is where Benadryl is completely appropriate, all right? For adults, you're going to give 25 to 50 milligrams. I'm going to keep it simple for you. Just give them 25 milligrams. All right, that's what most of these tablets come in. They're chewable, they're 25 milligrams. Just give them a 25 milligram pill. All right, they chew that up, they're good to go. All right, for pediatrics, it's going to be 1 milligram per kilogram with a max of 50. Okay, now moderate. Okay, moderate is going to be 2+ body systems. So that could be having hives and respiratory distress. It could be having nausea, vomiting, and hives. It could be all these different things. Now, that's the definition of that, okay? And one thing that we need to make sure that we're doing is that we are prioritizing epinephrine, okay? Which we're going to talk about that here in a second. All right. Additionally, albuterol, if there is wheezing and they have a prescription and the indications are met and there's no contraindications, then they can have albuterol as well. Now, Benadryl is technically in here, but I want you to notice how it says something right here. It says C pearls, okay? C pearls. So we're going to scroll down and we are going to find where it talks about, diphenhydramine and steroid administration, okay? So Benadryl have no proven benefit in moderate/severe anaphylaxis, all right? So moderate or severe allergic reactions, okay? This should never delay initial or repeat epinephrine administration, okay? And in moderate and severe anaphylaxis, Benadryl may decrease the mental status, all right? And then, even more, Benadryl should not be given to a patient with decreased mental status and or a hypotensive, so low blood pressure patient, as this may cause nausea, vomiting, and even worsen their mental status. Okay. So, for the purposes of this class, we're going to keep things really, really simple. Give Benadryl in mild skin-only reactions. There you go. Right, so again, just to sort of wrap this up for Benadryl, adults 25 milligrams to 50 milligrams. All right, and then what we're wanting to do here is just stick with it, keep it simple. 25 milligram dose for adults. Remember, pediatrics, 1 milligram per kilogram dose. All right, your contraindications for that are going to be, allergies and then unable to follow their commands, unable to protect their airway because it's an oral medication, as well as that hypotension. So, almost done here. We're going to be looking at epinephrine. All right, so epinephrine, we're looking at moderate or severe allergic reactions. We just looked at that protocol. Remember, this is going to be our first out drug for this and one of the most important drugs for these moderate or severe allergic reactions. Now, there are EpiPens that can be used, okay, but I've told you before, these are going to be very, 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 very few and far between, to the point that we're not going to even spend really any instructor time looking at this. You know, we're going to have a little bit of self-study on that, and then you're going to be able to use them, mess around with them inside the classroom. All right, what we care about the most, though, is getting our drugs out of our vials or ampules. All right, so just to rehash some dosages real quick. Adults 0.3 to 0.5 milligrams IM. Again, not a huge fan of ranges for y'all, so 0.3 milligrams it will be. Now, pediatrics, all right, if a pediatric, let's just say they're less than 30 pounds or less than 30 kilograms or less than 66 pounds. Sorry, it's almost midnight. Then they would get 0.15 milligrams of epinephrine. Both of these are going to be IM, intramuscular injections, okay? And there are no contraindications for it when used as indicated. So I want to talk to you about the differences between the ampule and the vial. Okay, so what you have here on your left is what is called a vial, and the one that is on your right is called a ampule. So you're going to notice that our epinephrine is going to be 1 milligram in 1 milliliter, and so it is a 1 to 1,000 ratio drug. All right, so here's what I want you to know out of this. You take a 1 cc syringe and you draw up all 1 cc or 1 milliliter, as the cc and the milliliter are the exact same for all intents and purposes that you need to know about right now. And all you got to do is, if you need a 0.3 milligram dose, is you give the 0.3 milliliters of it. Okay, it's really easy to dose this out. All right, now you have this medication here on the left, all right, in this ampule. I'm sorry, this vial. Then over here on the right, we have a ampule. Notice the difference, all right? So this one is all glass. And then right here where the mouse is, there's a little etched part. So what you have to do is you actually have to break this glass. And then it's a little bit of a process to get it out of either of these, but we're going to start with an ampule, okay? So we're going to grab our ampule, and we're going to put a little bit of pressure that you'll get to get your hands on, and you're going to break it right here at this etched point, and then you're going to use something called a filter straw on top of your syringe, a filter straw, because if we're going to break this with glass, right, it's reasonable to say that there could be some glass shards that make it into our medicine. Do we want to put that into somebody's body? No, we do not. So that's why we use a filter straw here. So that way this filter in here catches anything that we don't want. So with an ampule, once this is open, it's open. All right, so we're going to draw up every bit of this, all 1 cc of it. All right, so that means that if you have a 1 cc syringe, we are going to draw up all the way to right here. But we want to give, let's say, 0.3 milligrams of epinephrine as a single dose. So that means that we're going to push this plunger here to the 7. So that would mean that there is 0.7 milligrams of drug remaining in this syringe, and that we have delivered 0.3 milligrams of drugs. So that way, if we have to give another dose 5 minutes later, well, then we're going to push from 0.7 to 0.4, and that's where our plunger is going to stop. That's how we would give that medication. We have to have it all up in the syringe because an ampule, it can't be sealed back. It's open to the elements, it get knocked over, lost, whatever. All right. Um, so that's why we're going to draw all of that back up. Now, on the other hand, let's talk about a vial. All right, so we're going to kick this little plastic cap off. There's a rubber seal in there, and we're just going to take our needle and syringe, and we're only going to draw up exactly what we need. Because once you pull that needle out, that rubber is actually going to seal itself back up. And so we're perfectly safe at that point. So now we take our syringe, and we can draw from here right up to the 0.3 and then deliver that medication. All right, and then if we have to go back for more, we go right back into the vial 5 minutes later if we need to for more. All right, remember you can give epi as many times as you need to every 5 minutes as long as it's indicated. So if there's still 2+ body systems involved, we're going to give them the epi every 5 minutes. The last medication that I want to talk to you about is called glucagon. So this goes in the same diabetic hypoglycemic patient as you would use oral glucose for, except when oral glucose is contraindicated for an EMT because the patient is unable to follow your commands or is unable to protect their own airway, this is when we can go to glucagon. Now, glucagon is a bit of a process in itself to draw up. Maybe not as intimidating as breaking that glass ampule, which I promise you isn't that bad. But there are a couple little steps to it. So what we have to do is we have to come in and we have to draw up 1 milliliter of sterile water. Okay, 1 milliliter of sterile water. So we're going to take our syringe with a needle on it. We're going to draw all the way up to 1 milliliter here. Then we're going to come back in and we're going to squirt that 1 milliliter of water into this other vial here. All right, and this vial has 1 milliliter, 1 cc, 1 milligram worth of glucagon in it. So glucagon is a hormone, and it doesn't like to be stored as a solution, as being wet. All right, so it's in there as a powder, and once you squirt that in, all you have to do is shake it just about like that. Poof. It's all dissolved into your sterile water and is now a solution. Okay, it's not a suspension, it's a solution. It is fully homogenized with that sterile water. Then you're going to take your 1 cc again, draw it right back up to 1 milligram or 1 milliliter, and then you would go to administer that to the patient. Now, dosages. Let's take a look here. All right, for an adult, we're looking at a same indication really as your oral glucose, and they're going to get 1 milligram IM. So once you complete this process here, you've got 1 milligram and 1 milliliter, and you're going to give that whole 1 cc, 1 milliliter of the 1 milligram drug. All right, now, whenever we look at pediatrics, all right, pediatrics, whenever we come into our pediatric protocol here, all right, so let's say our oral glucose is contraindicated again. Glucagon, 0.1 milligrams per kilogram IM with a max of 1 milligram. All right, so you're going to see a question that's going to pop up here at some point. And what I want you to do is figure out what is the maximum weight in kilograms and pounds that I have to worry about doing this math for. All right, so just like with epi, we have the 30 kilograms, 66 pounds. All right, if they're less than that, they get 0.15 milligrams. So we're going to figure out what is the weight in pounds and kilograms where I have to do this math to figure out exactly how much glucagon they get versus just getting the whole 1 milligram. All right, so that's going to be a question for you to figure out. All right, so I know that was 45 minutes, but I wanted to give you just kind of a good overview of a bunch of this pharmacology stuff. Take a look And I hope you get these answers that or the questions I've been throwing at you correctly throughout this. It gets your brain thinking, and it gets you really prepared to come in for your pharmacology lab. Assuming at the time of this video that my schedule has not been completely screwed up again, I will not be there for your pharmacology lab, but Mr. Marsh will be, and he's going to make sure that all you guys are able to perform these skills appropriately. All right, so as always, feel free to reach out to me with any questions, and if you need to schedule one-on-one time, I will always make time for you. Other than that, happy studying and see you in class.